This content of this meeting is going to a third party. We accept, na?
No.
Sir, we are live on YouTube. Please, Rajiv Raman sir can start the proceedings of today's webinar.
Good evening, everyone, and welcome to the IAS Academic Corner November 2024 meeting. I would like to thank our President, Dr. Arumugam, our Secretary, Dr. Sandeep Biraris, and in association with Dr. Naresh Go to continue this meeting. And thank Naros for continuing for the whole academic year. So I'd like to introduce our expert moderator today, Dr. Vikram Mahaskar. He is from Delhi, a very well-known arthroscopy surgeon, a very good friend of mine, and Dr. Arvind Gupta from Patna. So over to you, Dr. Vikram and Dr. Arvind, for introduction of faculty.
Thank you, Dr. Rajiv. Thank you so much. And it's a real pleasure to be part of this wonderful meeting with such a star-studded group of presenters today. I would like to welcome Dr. Dey, Dr. Rajat and Dr. Siddharth for this meeting. And we hope to have an action-packed session with a lot of interesting cases that we'll discuss. So over to Dr. Arvind to introduce Dr. Dey, who's going to give our expert talk for today.
Good evening, everyone. Dr. Paresh Chandra Dey is a senior orthoscopy surgeon from Bhubaneswar, Odisha. We'll be talking on management strategy for complex knee cases. Over to you, Dr. Paresh Chandra Dey.
Can I share?
Yeah.
Yes, you can share.
Are you able to see me? My slides?
No.
Not yet, sir.
Okay.
You'll have to share your screen and then we. Yes, we can see it, sir.
Yes.
Slides show you okay?
Yes.
Yes, sir. We are able to see and hear you as well.
Okay. Welcome to everybody here, and I am very happy to see all of these people and like to start with the giving thanks to IAS, the Indian Arthroscopy Society, to give me this golden opportunity to speak here in the management of strategy of the complex knee. And here I am going to demonstrate, show you the two cases that we have operated in this year in 2024. They are the young people. One is 24 years, 22 years, another is 30 years. There are complicated knee. My initial phase of my training of arthroscopy started in 1995 in HN Hospital, Mumbai, with P.H. Vora, and then Dr. David Rajan, KMCH. In 1999 to 2010, almost I visited 10 times to Dr. Anand Joshi clinic. That was in Dadar. And I saw that he was operating in the Bombay Hospital, Bombay. In 1995, I was very much impressed when I was with the Dr. Professor K.T. Dolakia unit as a arthroplasty surgeon and resident of the arthroplasty surgery unit. I visited to many places like the Singapore General Hospital with the help of Dr. Mitra and the Professor Strobel Michael in Germany, Philippines, and Dr. Florin in France, about 4 to 6 times to France to see the arthroscopic surgery and reverse shoulder surgery. Come to the topic, that is a treatment algorithm for the chronic multiple ligament injury. This has been published last month in the Indian Journal of Orthopedics. The classical example of the 3 types of the best of the knee joint status, like limb alignment. Type 1 is the ligament deficiency in a reduced knee with normal alignment. Type 2 is the ligament deficiency with malalignment, where the deformity correction precedes the ligament surgery. Chronic unreduced knee dislocation necessitated open reduction and the extensive prior to the reconstruction, that is the type 3 variety. So treatment depends on the classification, emphasizing the realignment for the type 2 and reduction for the type 3. Now come to my first case, that is a patient of 30 years male, got an injury in 2021 with a road traffic accident of the right knee. And he came to me after 3 years of the injury and treated initially at this place with the plaster for a month and the physiotherapy. Consulted many states. He's from outside Odisha and many big institutes. Complaints of the pain, discomfort, unable to walk beyond 200 meters. Rest pain and mild varus thrust of walking and weakness, and also associated with the foot drop. So these are the status of the patient. foot drop, varus deformity, and also just foot drop, varus deformity, and he was demonstrating the laxity. On examination, it was a tight knee, stiff knee, so not able to, the excursions of the tibia was not possible. Even the varus valgus trace was not possible. So we did the scanogram. You can see the scanogram. It was also the left side. Also the left side is the normal side. Right side is the injured side. Right side it is definitely there is a varus deformity, but left side there is also a little bit of the varus deformity. Maybe you can say the constitutional varus, but it is only the difference is 1 degree. But you see there is a joint space reduction in the medial aspect, and there is a compressed fracture is healed in the medial condyle of the tibia, and there is multiple chip healed rim fractures, mostly the intraspect of the medial condyle of the tibia. We did the MRI, and that was the mid-substance clears of ACL and PCL, and the MCL also, but MCL almost healed. So diagnosis came out with the ACL PCL torn with the stiff posterior subluxated knee, torn MCL is healed, medial meniscus posterior horn vertical tear, and medial meniscus anterior horn avulsion, healed medial tibial condyle multiple chip rim fractures, varus deformity, and foot drop. So there may be this discussion of which one is to take up for the knee or the foot drop first. And for me, I thought to take up the foot drop first. I planned for the bridal procedure, and that was in the February 2024, this year. And this bridal procedure is for the correction of the foot drop. We take out the tibialis posterior from the insertion at the navicular tuberosity. We took the full tendon off with these insertions. We do not want to lose the length because it may be sometimes shortened. And then fit stitches and prepare the end of the tendon. Retrieved proximally about 8 centimeter proximal at the medial aspect. Tibialis posterior. And we try to retrieve again to the anterolateral aspect where the tibialis anterior is there. And the plan is to go through the tibialis anterior and the peroneus longus tendon, and then to the fixed to the middle cuneiform. So this is the antral aspect. Below the tibia, we pass the tendon of the tibialis posterior to the anterolateral aspect. So length will be adequate and we reach the middle cuneiform. Now we go to the lateral aspect that we try to retrieve the peroneus longus. Peroneus longus is superficial here. It is about 10 centimeter cranial or proximal to the tip of the lateral malleolus. We identify both the tendons, the peroneus longus and brevis. And we give an incision at the base of the fifth metatarsal where the peroneus longus is go to tip and go to the attachment at the first metatarsal. So this is the superficial in the peroneus brevis. Deep is the peroneus longus here. But the initial when they have the 10 centimeter cranial market proximal, the peroneus longus was superficial. We confirm that tendon and then retrieve at the lateral aspect of the foot, and below the retina is retrieved to the antral aspect at the tibialis antral aspect or tibialis antral tendon side. We made a hole about 7 millimeter as per the thickness of the tendon in the middle cuneiform, and both the tendon through the tibialis anterior and peroneus longus is passed to the below the retinaculum to the middle cuneiform, fixed to the biopsical screw, 7 millimeter into 23 millimeter. 7 millimeter, 23 millimeter. So foot drop is corrected. We have given the plaster for 2 months. After 2 months in the April, and then after 3 months, we thought to reduce the knee with the arthroscopic debridement and also the release of fibro. You can say arthrolysis. We did the arthrolysis. That time he was able to move the foot. There are dorsiflexion was possible, and the range of movement was about 5-degree extension lag to 115-degree flexion, and posterior subluxated knee. The lat side was positive. The movement was very much restricted. The Rathbone test was not so much, the excursion was not so, the tibia was not coming out so much. The adduction and abduction stress test was also negative. So we thought after say about 4 months of it was in February and it was in the June, we tried to open and do the medial high tibial osteotomy, open wedge osteotomy, along with the circumferential or maybe the posteromedial release of the capsule and the scar tissue. So we did that. The complete release posterior and posteromedial, and then the medial aspects. So finally, we reduced the joint. Almost the margin of the rim of the tibia is come up almost 8 to 9 millimeter entry to the, you can see and assess the reduction of the good. So after this will be the extension and then the flexion, the reduction will be good, but this is before the surgery or before the release. At the same sitting, we did the high tibial osteotomy. We given the Haver's marking, and then we saw, and then multiple osteotomy. We started at 4 centimeter below the medial joint line, and laterally about 1 centimeter below, and keep the bone in the 5 to 10 millimeter in the lateral aspect intact, and then the spreader, and we confirm with the long rod with the CR, and that was almost crossing at the midline or medial. So the varus deformity is corrected. The gap we have assessed with the spreader fixed with the Chromafix plate. This is not the original Chromafix. And this was the post of X-ray. And patient was able to bear weight after 7 to 10 days. It is on the 2nd day of the STO. Without losing much of time, we thought to reconstruct the PCL because there was a release posteriorly and medially, and the reduction was very good. Dislocation was reduced. After just 20 days, we thought to PCL reconstruction. And keeping in mind that the oblique screw or the vertebral screw may hit to my tunnel of the tibial tunnel. So that has come to my mind. And also we did that. We had to remove that on the table. This is the quad sternum here. There may be some confusion why the PCL reconstruction with quad sternum, but it is secondary stability of the PCL. It is about 6 millimeter apart, both the incision. We release the surface fiber from the petal, and then with the help of the scissor, release all around. This is the Rajiv Raman technique, very nice technique. He has published this technique. I have done about 20 cases. I'm very happy with this technique without any special gadget. Very long tendon, very tough tendons coming. It is around 350 millimeter long. The graph. I did the quads and the quadruple. So almost 89 millimeter long quadruple. For the PCL, it is almost 11 millimeter thick. Superficial tendon we have taken only without going to the joint, and 20 millimeter long for the femoral tunnel, given a mark with the white. This is gentamicin. So we've done the tunnel, lot of struggle to clean the joints, fibrous tissue, lot of fibrous tissue. We spent about 1 hour to do that. Then we made the tunnel of the about 15 to 20 millimeter, 18 millimeter below the upper surface of the tibia, and it is the graft, which is pulled to the joint now. The pillar torn was creating a problem. And this is my proof that is helping to overcome the pillar torn. This is the adjustable for the femur. So to manage to overcome that pillar torn problem, I fixed with the adjustable loop, the femoral side, tibial side, the suture wheel, and then the previous X-ray where there is the oblique screw is there. This is the oblique screw removed. This is 4 days before after the surgery, and then this is the fixation device of the femoral and the tibial connect, and this is the extra fixation of the portion of the PCL. After 3 months of the PCL reconstruction and the high tibial osteotomy in front of his house, patient was able to work. Foot drop is corrected, pain free. And then he came to me. He was able to climb the stairs. Very stable knee. Without holding the side bars, he can climb. And also come down. Foot drop is almost corrected. He was able to dorsiflex the foot a bit. So to complete the surgery for him, this month is the 2nd of the October, November. I did the ACL reconstruction. We got which is the semi-T tendon we have taken from the opposite knee because there was a foot drop and we have taken the cords and there was the high tibial osteotomy. The plate was there, so no more graft was there in the same knee. And this is ACL reconstruction, almost 9 mm graft. And again fixed this with the suture wheel and the underbutta. This is for the ACL and this is for the PCL. And the patient was able to clear weight in the next day morning and went home. This is on 4th of the November, 25th November, after 21 days, the wound is healed and the patient is able to mobilize, extend and flex. And also walking a few steps. Now, before going to the second case, this is my teachers or my mentors, Dr. David Rajan Ipandatu, Dr. Anand Joshi, Dr. Michael Strobel is a foot knee surgeon. I was in about 1 month with him in 2005. Dr. Pat is a shoulder surgeon from Germany, and Dr. Mitra is from Singapore General Hospital, SGH. And Dr. Philippe Collin is a shoulder surgeon from Germany again. This is Dr. Florin from France. I visited about 6-7 times to him to learn the single technique. This was my initial phase of practice in 1997 when I was using, not able to purchase a monitor. I was using this TV, LG TV, about 16 inches TV that time. Now the scenario changed. I have a 3D camera and 3D 4K camera of 55 inches. Now come to the second case. Should I continue?
Please
Please continue, sir, please.
Yeah, okay. So this is a second case, again younger than the first boy. It was the first boy was 30 years and it was the right knee, but this boy is 22 years with the left knee. He got an injury of a road traffic accident in May 2023. That is part May 2023 and dislocated. So all the 4 ligaments KD4 along with the MPFL. And this was after 5 days the MRI done in this place. That is 8 May 2023. And that was the October 2023. He got an X-ray and showed me that was he repaired with the MCL and then also the repaired the MPFL with the anchors. But they got infected. So 5 months he tried with the all medicines, lavage, everything, but they failed. So he removed this all the anchors and the screw in the October and November. He gave the all the cement beads, and the 3 cement beads he fixed with the K-wire and went get to the patella and medial condyle of the femur. And there are a lot of beads, almost like a necklace, usually inside the joint. And the patient came to me in the January 2024, first week, with the full leg was swollen, multiple discharging sinus all around the knee, both medial lateral side, lot of scars. Range of movement is only 5 to 10 degrees. Stiff knee, arm, thigh, and calf muscles like a log of wood. So this was the situation under anesthesia on the 3rd January 2024. I forcefully manipulated the joint, and there was a lot of pus pockets all around the joint. And I removed all the beads that he has given. It is like a necklace inside the joint. And I removed that K-wire fixed with the widths. After 15 days, I got an X-ray and found there is a lateral and posterior subluxation of the knee. And this is after 1 month in this February, I thought again debridement of the joint. So this is the second round of joint laments and the debridement, the thorough debridement. A lot of fibrous tissue in the bedside of the knee, the posterior compartment. Everywhere I debrided very nicely. I spent about 1.5 hours to debride the joint, all the compartments, all the 3 compartments. In the March 2024, it is about 2 months of the initial debridement. I give again the X-ray. It is the first X-ray, posterior and the lateral subluxation, lateral subluxation. But the wound was healed. Patient was very happy. So we thought to reduce the joint with the leisure of week. That was in a 3. After 3 months, I got the patient in January. And the leisure of being after 4 weeks, they almost reduced the posterior and the lateral subluxation corrected, almost 90-95% corrected. But the stiffness was there. So I thought to remove the central pivot that connecting the rods, and then the arthroscopy I did. Arthroscopy lavage with the ring on the May 2024. And got the flexion about 90° on the table. Lot of lavage, lot of debridement, lot of fibrous tissue, arthrolysis I did. About 1.5 hours, 2 hours. So posterior subluxation and the lateral subluxation were corrected. Laterally, there was no so much of gap on them. The CR picture, but medially there was a gap. And that is no posterior subluxation, no more posterior subluxation. That is beautiful. Patient was very happy. We were able to watch a few steps after 2 months of the, it is about 6 months from the beginning when I take over the patient in January. This is in July. I was able to watch 2 steps. The posterior lateral subluxation is corrected. Bend the movement from 0° to 110 to 120 degrees. I did the X-ray again in July. The 10th of July, I thought for the PCL reconstruction. Again, there was a debridement about 1.5 hours. A lot of fibrosis. It was the infection control. Everything is finished. 6 months passed. And this is the, I took the peroneus valgus. They were 2 centimeters proximal to the tip of the.
Sir, we have another 2 minutes because can we wrap up in 2 minutes and then go into the discussion?
Yes.
Yeah,
So this is the graft about 4-fold, about 9 millimeter long, 9 and 10 millimeter. And this is the same way I did the lot of fibrous bands in the posterior aspect. So I just tried to take out the PCL graft from the tibial tunnel. And this is my femoral tunnel. Femoral tunnel was 9 millimeter thick graft, and it is about 8 millimeter from the posterior the cartilage margin anterior. So on table, the fixation again the endo button and the suture wheel. The medial gap was there after PCL reconstruction, lateral gap was not so much. So we thought just after 4 days of the planning of the PCL reconstruction, we were planned for the MCL reconstruction. We did this X-ray on table to see the exact location of the MCL proximal attachment. That is the 10 millimeter, 14 millimeter, and 60 millimeter away from the upper joint line of the medial aspect for the fixations of the superficial. There was a deep lot of fibers were there. So we thought to repair the deep MCL on the superficial MCL reconstruction. This is the isometric test at the extension and flexion with the TMRs on, both the tibia and the femur. And the femoral side is fixed with this adjustable loop, and tibial side is also adjustable loop. And then we fix the 14 millimeter distal, that is the proximal attachment of the superficial MCL in the tibia with the bite taken from directly from the bone, not the anchors is required here. It was just the osteoporotic bone like. So I took the bite directly, contested. The medial stabilization was very nice. And then required the deep MCL. And this is the 7th of the November. We were able to stand on 5° lat to the activation and 110 to 120 degrees. It was an X-ray. And he was also able to climb the stairs. So he was able to climb the stairs and holding the box in the net. But there was not so much comfortable time. Thank you, friends. With regards to my mentor, multi-ligament injury, Dr. Mike Wickstrom.
Thanks a lot, sir. Sir, just a couple of questions because of paucity of time. Number one, in your first case, any tips and tricks of doing a PCL reconstruction with a HTO? So distally, when you're drilling the tibia, any particular tips you would like to give our audience as to prevent the screw coming in the way, etc.?
Yes, screw actually came to the on the way, and it was mentally I was prepared that oblique screw or the you can say that buttress screw we just removed it.
Great. And I think nowadays you have these modular screw holes also, where you can change the direction of the screw at the
Yes.
back. 4 and 5. So those are screw tricks one can do.
Polyaxial screw.
Yes,
Polyaxial, yes.
polyaxial, yes, absolutely. Dr. Arvind, any questions or can we move on to the next?
Yeah, just only thing about the reconstruction of PCL and ACL in two stage in the first case. We can go the simultaneous reconstruction of PCL and ACL at the same time. That's it.
Yeah, ACL, PCL, MCL I did or I do usually within 2 hours of tourniquet time, one tourniquet time. But this was a so stiff knee and there are a lot of infection was there inside. There's subluxation, dislocation.
So in the first case, sir, I'm just talking about the first case.
First case also I spent about 1 hour to release the postural fibrous tissue. So I spent a lot of time. So I do not want to, because there was already a foot drop, there was neural palsy. So I do not want to keep a tourniquet time.
So I agree with you, sir. I think peace of mind is very important as a surgeon. If at any stage you feel that you're getting fatigue, no harm stopping, coming back the next day and continuing.
Yes.
So with that, I think let's move on to our next case. And our next case is by Dr. Siddharth Agarwal. He's a very senior orthopedic surgeon, knee and shoulder surgeon from Chandigarh, very academically inclined gentleman and a great friend. So over to you, Siddharth. Please go ahead with your wonderful case today. And thank you so much, Dr. Day. It was just amazing and enlightening for everybody, and we've learned a lot. Thank you so much.
Excellent case. Excellent case,
Thank
Dr.
you, Raman.
Yes.
Everyone, and thank you, IS, for giving me this opportunity to share a case which I recently had a struggle with. So this is my screen is visible.
Absolutely, yes.
Visible.
Sir, please change to slideshow. Yeah.
I think, is it okay now?
Yes, sir.
Yes.
That's
Perfect.
Yeah. So the case of a posterior ankle impingement that I handled 2 years back. So I am a arthroscopy surgeon practicing at Chandigarh, and thank you all for being here, all my dear friends. So we'll start with the case. So what exactly is posterior ankle impingement? We all know there is pain and restriction of movement. It is mainly associated with activities such as running, jumping, and repetitive plantar flexion. It's most common with fast bowlers, swimmers, and football players. Anything that involves repetitive plantar flexion activity. So common causes are bony, that is os trigonum or posterior talus osteophyte, or a FHL, that is flexor hallucis longus tenosynovitis, or a posterior talofibular ligament impingement. There are few uncommon causes that we rarely see, just for the enumeration I've written. What's my patient profile was a 18-year-old. He was a fast bowler hailing from Punjab and was playing under 19. He had pain in the ankle in the landing foot for around 8 to 9 months before he presented to me. So the clinical picture, I did the sudden plantar flexion test. There was acute pain. There was localized tenderness at the posterior part and the lateral medial to the ankle. There was tenderness along FHL. There was mild tenderness along that. So I did the X-ray. I saw a os trigonum at the posterior aspect of the talus and the subtalar joint, very clearly visible. So he wanted conservative management as expected. So we tried that. First of all, we got the MRI. On MRI, we can see a proper bony piece of os trigonum along with the associated edema around it. The FHL looked pretty okay on the MRI. So we went ahead and diagnosis of posterior ankle impingement along with mild FHL tenosynovitis was made. So we tried with anti-inflammatory drugs, icing, rest and activity modification. He did take rest for a few days, but as expected, these guys are not very good with the break. The physio and rehab was regular. He was not good, not happy. We gave him 2 injections of steroid around 4 to 5 months apart, both under image guidance. He was happy with the pain with the first injection. He went ahead, played for 3-4 months. Then again the pain came. Then again he took for the injection. Finally, after around 6-7 months, we decided for the surgery of the posterior impingement in October 2022. So we did adsorb debridement of the area, and the os trigonum fragment was removed, as seen on the photo. The rehab was done properly for 3 months. He was non-weight bearing for around 4 to 6 weeks. This is the intro picture that we had. This was when we went in, there was synovitis all around. So we did a debridement of the tissues in the posterior ankle area. There was standard 2-portal posterior arthroscopy with a posterior lateral and posterior medial portal around the tendoachilles. So we cleared the soft tissue and the fat around the fragment. This is the fragment that we can see, the os trigonum fragment. The FHL can be seen in the deep with a brownish muscle mass over it. It looks to be healthy. There is no significant synovitis around it. This is a fragment that we can very clearly appreciate in the posterior part. This is after some debridement. I started cutting and taking down the attachments of the fragment slowly and slowly. So finally, the fragment was isolated. This fragment is almost separated now. Try to catch it with an artery. Finally, we are able to take out the fragment comfortably. After removal of the fragment, this is the posterior aspect. You can see the FHL in the background. This is the posterior talus osteophyte that we can see, and there is the subtalar joint beneath. So we use the burr and flatten this osteophyte and the soft tissues around it, which was still causing impingement. There was still some debridement going on. I feel that maybe I left 2-3 mm of the osteophyte of the posterior aspect of talus, which could have been removed at this sitting. And this is what I felt when I saw the video in the retrospect this time. So this is the post-op X-ray, what it looked like, which was pretty beautiful and encouraging. So I was pretty happy with it. And I kept him non-weight bearing for 4 weeks, cycling and partial weight bearing till 6 weeks. We started full weight bearing at around 6-7 weeks. He started field training at 8 to 9 weeks and is back to bowling at 3 months. And he played pretty good for next 4 months. He was bowling at full speed and he was happy with his progress, pretty happy. Then suddenly one day he called me up, sir, I bowled 5 overs and suddenly I had a swelling in the ankle region, posterior aspect, with no pain. But there is a swelling. So he came to me. I saw that there was swelling, but there was essentially minimal pain. So I gave him rest and anti-inflammatory and settled 4-5 days. After that, he again played, but there were recurrent episodes of pain and swelling. Every 15-20 days, he said that he has some pain, some swelling. So he managed this conservatively. We repeated the MRI. It just showed inflammation and there was some fluid around that area. Blood workup was negative for CRP and in infection. There was no fever. Then he went around. Somebody gave him a steroid shot and there was again some relief. Then he came back. I gave him one more steroid shot ultimately in this period of this turmoil. So finally, we got a MRI repeat. There was some fluid. So we aspirated the fluid and ultrasound guidance around 4 months back from now. That is in this 1 year, all sort of things were tried. The fluid came out to be sterile. On culture, there was an evidence of 1 or 2 gram positive foci, but essentially it was sterile. Even the color was almost serous and clear. So this is the latest X-ray just 2 months back. So if we can see in this not very so good X-ray, we can see a osteophyte which has developed, which is marked by an arrow in the posterior aspect of the talus compared to the post-op X-ray I put across to the comparison. This was the post-op X-ray 2 years back, and this is the X-ray 2 months back, that is present date. So we can see a bony osteophyte which is not seen on the post-op X-ray, which has probably developed over this period of time. So this is something I searched all around the literature and could not find any evidence of developing of an osteophyte. Probably the chronic inflammation was the cause. This is the repeat MRI just 3 months back. And if we can see it on the third image, we can see a projecting osteophyte, which is probably the cause of the impingement, and there was inflammation around it. So I convinced him, and we again went intraoperative. This is the big osteophyte on the first image that we can see at the posterior. This is the posterior aspect of talus. There's tibia on the top and calcaneum underneath. There's a big osteophyte that I could find inside. And after debridement, after cleaning of it, this is the FHL that we can see clearly. It showed some fraying of the synovium, some evidence of fibrosis, but no essential synovitis on it. This short video for the second surgery. This is when I went and did some debridement. I saw this osteophyte, which is pretty huge and very much similar to the os trigonum that we had excised earlier. So we did some burring and we did all the birthing and debrided this. You can see the FHL in the background, which looks to be okay. There was some soft tissue fibrosis around this area, which we also debrided along. And one thing I would like to put across for the youngsters, first thing that you have to understand is that you have to identify FHL and stay lateral to it. Just remember this thing in when you do scopy. So at the end, we were debriding this fragment, bony fragment. This osteophyte was thoroughly debrided. So this video is a bit haphazard. So this is a picture after nearly complete debridement of this fragment. So the post-op X-ray this time, this is around 1.5 months back. And again, it looks to be pretty happy with no bony thing around this. So what does the literature say about it? There are very few literature studies which talk about the recurrence of posterior ankle impingement. Very, very few. And there was this biggest study in 2018, which had a study of 2003 patients with a reasonable around 10-year follow-up. Outcome was similar for different type of impingement, whether soft tissue or bony. The recurrence it is stated was 5% on all the patients. But what they did and how did they manage, what were the specific causes they identified were not discussed in the study. The conclusion that they put across was that additional FHL tendinopathy was associated with a lower satisfaction and a higher recurrence rate. Another study I could find just mentioned the recurrence rate was around 6.6%, which required surgery, nothing more mentioned. Again, this study mentioned the relationship with the FHL. If there was a tendinopathy or tenosynovitis of FHL, the recurrence rates were nearly 40%. So common stated recurrence causes that I have found were the insufficient rehabilitation or return to high impact activities too soon, which was not there in our case. Failure to address the soft tissue pathology, that is the FHL part, that is one of the common causes of recurrence. Inadequate bony resection or the soft tissue debridement, and FHL pathology to be persisting. So what in our case I felt was the problem was probably the persistent inflammation which stayed there for a year, which led to increased vascularity, led to the development of the posterior talar osteophyte, which was the cause probably for the recurrence of the impingement. What the issue I faced in this case was that the biggest challenge everybody was putting across, this bone may have been left during the primary surgery. That was the first thought everyone had, even myself I had. So when I went back to all my records, so I saw that is a new osteophyte which has developed over this last 1.5 years. And throughout literature, I really could not find any evidence to support this. So this is what I want to say, that if in case you have a recurrence, rather than just jumping that the primary surgeon may have left some bone or something inside, there could be other things more to it that we can look for. Thank you for your hearing. Short and crisp
Wonderful case, Siddharth. Very nice. And I think the moral of this story is a lot of these degenerative conditions where you have osteophytes, etc. It's very hard to predict what kind of result you're going to get at the end of it. So I think you did what is best for the patient. You removed whatever was there at time 0. But I think the condition is such that it has a very high preponderance for recurrence. Anything, Arvind? Anything else?
I was surprised to find the second time the osteophyte was pretty huge, almost as big as the initial bone fragment. And it was not there very clearly as we saw in the first video. It was very clear in the first video. So it was surprising for it to develop in a young now 20. He's now 20, playing for Punjab. Would be playing for Punjab.
Correct.
Chalo.
So I think a lot of these fast bowlers, the delivery stride takes a lot of
Yeah,
pressure
the
on
landing foot they develop. I have done quite a few number, around 10, 12 of them.
Correct.
Fast bowlers with the posterior ankle impingement. The landing foot takes it all and they develop this.
So there's this mixed action in bowling. So front arm, side arm, and mix. The mixed is the
Yeah.
one which has maximum of these kinds of
Yes.
biomechanical.
Side arm is good as so far as these type of injuries are
Okay.
concerned. But mid stance is the commonest one that they use.
Anything else, Arvind? Would you like to contribute to this?
Yeah, very good case presentation, Dr. Siddharth. Most of the time, these ankle pain, whether it's posterior ankle or anterior ankle or lateral ankle particularly, got missed by many, even orthoscopy surgeons. So things has to be keep in mind that always your Kennicott or steroid is not going to work. You have to identify the primary pathology, what is working here, particularly all the active athletes who are in very high contact sports and all this. And as you have removed the os trigon in the first your video, the condition of posterior talus was not very good if you see the video very carefully. So
Yeah.
that is one of the reason that the reason behind development of the osteophytes. It was looking like very degenerative type of condition there.
Yeah, I felt that I should have removed maybe 2-3 mm more in the initial setting. So maybe that could have helped. But that is all in retrospect. Once you remove such a big fragment, you are so happy about it. You're so excited, big 2 centimeters fragment, that you are like done with the surgery.
And again, many congratulations. Your second surgery given relief to the patient, because many a time surgeon used to refer the case to go to some other place. And
He went all around the Tri-City and then he came back to me.
very good case, Siddharth.
Good.
Thank you, Dave.
I think
Thank
Dr.
you.
Arvind, you can introduce Rajat for his last case.
Yeah, Rajat is very good friend of mine.
Good evening, sir.
Also, good evening, dear. So he'll be presenting management of neglected ACL, TBL, spine eversion fracture case. Rajat,
Thank you,
over
sir.
to you.
Go ahead, Rajat.
Yeah. So is the slide visible?
Yes, you can put it on play mode, please. Yes, perfect. We can see it. Go ahead.
Yeah. Good evening, all. Myself, Dr. Rajat Kapoor, and thank you, Indian Arthroscopic Society, for and all for giving me this opportunity. I am presenting the management of neglected ACL tibial spine avulsion fracture. Tibial anterior cruciate ligament avulsion fracture is an uncommon injury that usually occur in children and adolescents, and frequency is about 3 in 1 lakh. The most common mechanism of injury is the low velocity trauma as well as high velocity trauma. The signs and symptom: if the bone union knot occurs, then it results in a loss of knee extension, pain at knee extension, and anterior instability of knee. The classification, as we all know, that the type 1 is the undisplaced fracture of tibial eminence, type 2 partially displaced fracture, type 3AB is the completely displaced fracture of tibial eminence, and 4 is comminuted tibial spine fracture. Non-operative treatment in form of immobilization is indicated for fractures. Operative treatment is indicated for type 2, 3, and 4 fractures, as these displaced fracture can develop non-union or malunion, resulting in a knee instability, anterior impingement, causing loss of knee extension. The surgical technique include the open or arthroscopic reduction and ACL reconstruction. Open reduction and internal fixation involves the arthrotomy, soft tissue dissection, prolonged immobilization resulting in high chance of knee stiffness. The fixation options, we can use the wires, staples, screw, and sutures. The advantage of using sutures is that they provide very stable and rigid fixation and don't need removal. So we took a different path and successful with our results. Initially history and physical examination, stability test. The lateral view X-ray flexion inflection is put for tibial spine fracture to see the size of the fragment. CT scan, MRI is excellent for evaluating not only the bony ACL but other soft tissue associated injury. The standard procedure AM portal technique we use for the ACL reconstruction after clearing the fracture bed, done with a hamstring graft. Rehabilitation. There are several literatures showing that non-union ACL tibial spine avulsion fracture managed with the arthroscopic ACL reconstruction. But sometimes interop initially we planned with a fixation, but sometimes there will be, what we find that there is a mismatch of the fracture ends, decreased potential of fracture healing, a sclerosed margin, degeneration of ACL fibers, and thus we have to go for a ACL reconstruction. This is the case one patient presented with a complaint of instability, give way, and inability to extend the right knee from 11 months. On clinical examination, the anterior drawer, Lachman, and pivot shift is positive. There is 10 to 20 degree of extension block is there. This is the pre-op X-ray. MRI. Video is not working. The video showing the 10 to 20 degree of the extension block. The patient managed with the arthroscopic ACL reconstruction after removal of the avulsed fragment. This is the intraop picture showing the torn ACL fibers with the tibial spine and committed tibial spine fragments. And the fragment impinging the preventing the knee from extension. This is immediate post-op after ACL reconstruction. Post-op X-ray.
3 months.
At 3 months. At 6 months follow-up. One-year follow-up of the patient. And this is 2-year follow-up. Case 2 presented with the instability given locking from 2.5 years. And the test of instability is positive. This is the X-ray. MRI is showing the comminuted tibial spine fragment. Patient managed with the arthroscopic ACL reconstruction with quadruple hamstring graft. And there is in this case, I find that the comminuted spine fragments are attached with the anterior horn of the lateral meniscus. So while doing the debridement, we have to sacrifice some of the anterior horn and last repair it with the capsular repair of the lateral meniscus done. This is intraop. This is the one of the big chunk. When we removed it, it is attached with the anterior horn of the lateral meniscus. So 6 months follow. Video is not working. So finally, for the patient, no locking, no pain, early weight bearing, full range of motion, near normal knee and return to pre-injury activity level. For surgeon, there is a sound sleep with no worry, excellent result. Most important, satisfaction of better cure. So arthroscopic ACL reconstruction technique in a non-union tibial spine avulsion fracture is effective with good knee stability, better range of motion, and good functional outcome. Thank you.
Very nice, Rajat. Very good case presentations. I think there is a couple of articles by Dr. Dhillon and the PGI group about
Yes,
the malunited and non-united fragments. So it's been shown that a lot of cancellous bone heals at the bottom. So you
Yes,
need to
sir.
get rid of it to create a crater that is slightly deeper than the fragment itself, so that
Yes,
it
sir.
subsides into that crater in the new.
Yes, sir.
Arvind, anything else? Any other points you'd like to touch upon?
So, Rajat, what is the maximum duration till what you will repair this ACL spine avulsion?
I have done, sir, around 10 to 12 cases. Most of the cases, one of my 8 to 9 cases are almost around 1 year or more than 1 year old. But last case I did, it is around 6 months old. I tried fixation, but the ACL fibers are too much degenerated that bite out हो गया था, sir. So then I done the ACL
Arvind, what is the
reconstruction.
maximum you have fixed?
Sir?
It's for me, it's depend upon the fragment size.
Till
So I
now,
have
how
fixed-
what's the maximum you have fixed?
For 2 years, I have fixed, but not with the orthoscopic mean. This was very big chunk, almost around 3 into 2 centimeter it was. Even it was little bit bigger than that. And I curated both the base and the under surface of the ACL spine. And then I fixed with the 2 screw in the lag fashion. This was mini open orthotherapy method. So that was the maximum. But I do fix at 1 year also. In one of the child recently I have fixed, he was 11-year-old only, and that was 1 year old. So again, it's depend upon the size of the bone, and I also look the intensity changes in the MRI. If it is at the end of 6 months, there is a lot of intensity changes in the MRI, like early mucoid changes. If you can, then many a time it's not worth to fix it. So if there is no other changes in the ACL and the fragment is big, then I try fixing it. And in my head, all are doing really good. Don't have any complaint about it. Particularly in the children, I usually try to fix even at the end of 6 months, 7 months, 8 months.
So usually these chronic ACL avulsions, more often than not, don't present with instability but with impingement. So you'd have them with a inability to extend the knee completely.
Extend.
So
Yes.
I think getting them back in place more from a stability perspective is basically to get the knee biomechanics moving and the knee in extension so that the gait improves at the end of the day. But yeah, wonderful cases. And I must compliment that all of you all have chosen these cases so well, and you know, we all get to learn something from what you all are doing. So wonderful, and 3 kudos to all of you all. Wonderful, great job.
Thank you so much, sir.
So can we conclude, Naresh?
Yes, sir. Yes, sir. Please.
All right. Okay. And thank you, IAS. Thank you, Naresh, Sandeep, Dr. Rajiv, everybody for having this great session. Dr. Arvind for his experience and wonderful contribution to this, and our 3 esteemed faculty. And before we sign off, 3 cheers to IAS.
Thank you very much, gentlemen, for joining. This is a wonderful session today. Thank you. Good night.
Thank you, Dr. Naresh.
Bye, sir. Bye. Thank you.
Thank you, sir. Good night.
Thank you, Rajat.
Thank you.
Good night.
Thank you, sir.
Yes, sir. Thank you. Good night, sir.